So good afternoon, everybody, and this is a really interesting, tricky little facet of taking care of chronic pain, which is the care agreement. And really, what I want to do is present a subtle but super important paradigm shift, a little philosophical way of thinking about a care agreement that I think can make them way more useful and effective in keeping chronic opiate treatment safe and manageable for a clinic. And so, general disclosure is that I have none, and I accept no money from anybody. If anybody has some, yeah, that's right. If anybody has some, but I have no confidence.
We'll pass the hat.
Yes. But so I guess so. Yeah. So the three things I want to cover really quick are a care agreement. What is it really for? What should be on them, and how should they be used? But I think like I said, the big philosophical concept to think about a care agreement is really as a communication tool. That such an important feature of providing chronic opiate treatment to people with chronic pain is communicating, is number one, having well-defined clinic rules. So every clinic that provides this care for patients needs clear and firm rules for how they're going to dispense chronic opiates. And that it doesn't really do much good to have these rules if these rules aren't communicated really clearly to patients. And the main reason is that just having the rules does not really fulfill the main goal of the rules. The main goal of the rules is for patients to know them and to follow them. And patients can't really follow them if they don't know what they are. If those rules aren't communicated well, and then patients don't follow those rules, you can really be stuck in a bit of a limbo. You don't know, did the patient break those rules because they are at high risk of prescription drug abuse, or did they break the rules just out of sort of ignorance that they just didn't know that that was a rule, and it doesn't really mean that they are sort of abusing the opiates, as it were. And so the key concept is to think about this care agreement as the key vehicle, key tool, key framework for that communication of what the clinic's rules are. So as soon as you start thinking of them as a communication tool, it really immediately sort of leads to the idea that those care agreements should be as simple as possible. Of course, they need to be written down, and really think of them as a communicating, these are the rules of the clinic. And in terms of then how you can use them, if you really are sure that you are carefully communicating them, then all of a sudden they become this really key tool that helps you to better identify which are patients who you should be suspicious of for prescription drug abuse. Because when patients understand the rules, but they still don't abide by them, it's much more clear that they're not safe candidates for chronic opiates. And so then, that leads us to the really sort of tricky terminology that is sort of rife for stumbling, which is that everybody calls a care agreement a pain contract, and it is so hard to break away from that sort of old term, and I am guilty of sort of stumbling back into it all the time, and to try to get people to stop calling them contracts and start calling them agreements is like pulling teeth, and yet it is really that terminology is at the core of the philosophical reason d'etre for the agreement, which is that a contract is something that you think of that no one actually ever reads. So a contract is something that is full of sort of fine print that's not necessarily meant to be a communication tool or or something that you would actually sort of take home and sort of really digest. You might have your lawyer read a contract, but people don't read contracts. But this is not that. What a pain agreement is really something that you want people to read. You want them to understand it, and so that's sort of at the core of why it's important to think of it as a agreement and not as a contract. And so, for that reason, you want to try to keep them short, because the shorter they are, the more likely patients will read them, and the easier it will be for clinicians to review them face to face, and the more confidence you're going to have that they really were communicated clearly. Another way that they are not contracts, like if you think of a contract, you think of a contract. I mean, the reason that contracts are so long and so full of fine print that people don't really read is that a contract is designed to sort of have the legal perspective that every possible little sort of nuance or detail is going to be included in the contract. But that's not really what this agreement is. A care agreement is never going to take the place of clinical judgment. So for example, if I promise that I won't use illicit drugs is not on the agreement, and then a patient sort of is found to have used cocaine, it's still perfectly appropriate for the clinician to use their clinical judgment and decide that this patient is no longer a candidate, a safe candidate for chronic opiates. And it doesn't matter whether it was on the agreement or not. And so I guess that the main point is that it's not a contract. If something wasn't there that is a clear red flag for abuse, it doesn't mean that you can't, your hands are tied and you can't stop the opiates because it wasn't in the agreement. An agreement is a communication tool of the clinic's rules, but it does not at all take the place of good clinical judgment. And so here I've sort of boiled down, if you're going to try to make this as short and sweet as possible, to me the 5 most key features that should be on every care agreement are up on the slide here. I can tell you that the UW Medicine standard care agreement is much, much longer than this. And it's hard when you're in a big group and you're trying to reach consensus, and everyone is going to have their sort of favorite sort of feature that they think is really important to always be on a care agreement. And so it can be hard to come to a consensus of sort of what the small, compact, and easy-to-read agreement should look like. But I think as a bare minimum, these are the 5 features that you want, which are that medications can't be refilled early, that refills require a clinic visit by appointment, that they can't be requested urgently, that you need at least 2 business days in advance to try to meet a patient's needs, that lost or stolen medications or prescriptions can't be refilled, that have to be safeguarded as if they were cash, and that failure to follow these policies may result in discontinuation of pain medications. So these are the key features that patients are most likely to stumble into in a kind of naive way of like, oh, gee, I didn't realize I had to be that careful. That if you are really careful to have communicated to them and then they're still not able to follow it, that is the really helpful sort of hang your hat on feature of their case that helps you to feel more confident that they are not a safe candidate for opiates. And so that sort of leads then to how are you going to use a care agreement. And I think the common pitfall is, especially when the agreement is so long that you can't even really sort of easily communicate or talk to a patient about it, sort of the pitfall is that the provider will just like leave the agreement on the exam table and then leave and say, just sign this, I'll be right back. And then it's sort of filed away, and that's sort of the end of the agreement. And I think when you use agreements in that way, you are missing out on that key, important, useful feature of an agreement, which is that it is a communication tool, which is just the one-time signing does not really meet that goal. What you really want to be doing is reviewing it with patients, maybe on several visits, so that you can be really, really sure that they clearly are understanding. You're going to get better adherence to the clinic rules if you do that, and you're also going to have a much better, clearer sense that if patients are still not able to follow those rules, that it is the better part of good clinical care to discontinue opiates in that case. The other key that makes care agreements even more useful is to make sure that they're easy to find in the chart. And so, especially for your support staff who may be talking to disgruntled patients on the phone, if the support staff are easily able to find that agreement that was clearly documented as communicated to the patient, it gives that support staff on the phone really important psychological backup that they are trying to adhere to the rules of the clinic, which it was clearly documented, have been clearly communicated to the patient. And so for that reason, there are all different ways of trying to make sure that a care agreement is easily located. I think we have, and this is the evolving electronic medical record, and more and more people are using Epic, but everybody has slightly different versions of Epic that they're using, or implementations of Epic that they're using, and there are many different sort of features of Epic and of many EMRs that not everybody has access to. Still here at the University of Washington, the key way that we document these care agreements is as a letter to the patient, which is printed and handed to the patient and then shown as sort of delivered to the patient. And as long as you put a clear sort of subject line for that letter, so it's easy for somebody to find, that is still the easiest sort of workaround that we're at least using in the general internal medicine clinic at UW Medical Center. And so that is the end of my slides.